Thank you. First, I would like to thank the organizers and the scientific committee for giving me the opportunity to uh, for presenting here. Uh, it's an honor to be here, be the part of ISOT meeting, and I will be presenting the Delphi consensus on brain-dead donor feasibility. This is a topic that reflects the evolving clinical practices and the need for standardized evidence-informed decision making, especially in the deceased organ donation and transplantation. 1 year ago, in for midterm ISOT meeting in Nasik, we have dedicated the midterm meeting of ISOT, especially for the this consensus meeting and the topics which are very gray and they don't have good evidence. So that topics were discussed. As we all know, India faces an acute organ shortage. Despite having structured various deceased organ donor programs, many potential brain dead donors are not utilized due to uncertainty about the suitability in the real world ICU settings. A large proportion of potentially viable organs are discarded prematurely, and that leads to more and more gap in the transplants. We have the lack of uniform guidance for the clinicians on the donor acceptance, especially in the marginal cases or complex cases. Existing guidelines emphasize on the logistics and the ethics, but not on the clinical feasibility. ISOT has taken the initiative. They have made the multidisciplinary expert panel to develop an evidence-informed Delphi consensus applicable especially for the Indian context. If we see India, it ranks globally second in the absolute number of transplants after USA. In that, deceased organ transplant accounted for close to 18% across the nation. And despite the robust infrastructure, the deceased brain dead donor utilization rate is low. There are many organ discards are there. So donor recognition and selection criteria remain non-standardized across all the states. ISOT and has many times mentioned that one nation and one policy. So the landmark policy enabling the national uniformity in organ allocation and registration. So the key points in this is the removal of the upper age limit for the recipients, abolition of state domicile restrictions, and more emphasis on the unified national waiting list. So all this expected to enhance the cross-state organ sharing and expand the access to the transplantation. Coming to the expanded criteria donors, the rationale is that traditional focus is on the standard criteria donor exclusions, but ISOT emphasizes ethical expansion to include the donors with the AKI, controlled diabetes or hypertension, advanced age, donors with the previous infections or the other anomalies or illnesses. The objective was to maximize the safe utilization of the organs that would otherwise would have been discarded. The aim was of the consensus was to develop the India-specific expert recommendations on the feasibility, risk assessment, and ethical utilization of the organs from the marginal donors. The primary goal is to standardize the evaluation of high-risk brain dead donors, expand the usable donor pool, and promote the self-sufficiency and reduce the transplant inequity. Coming to the methods, comprehensive literature search, including the PubMed, Google Scholar for the global data as well as the Indian data. Evidence categories are in the form of guidelines, cohort studies, and the registry analysis and the case series. Gaps were identified in the India-specific context with evidence prompted reliance on the expert consensus. The modified Delphi process is in the form of 2 rounds of anonymous online voting to minimize the bias, and the accepted statement acceptance is on the more than 70% agree, strongly agree is required for the statement. Each expert panel reviewed a specific domain like AKI, infections, malignancy, and the other key issues. Outcome synthesized into 19 final statements. These statements covers usually the issues like donor with the AKI or the renal injury, then the extremes of the donor age like less than 10 years or more than 65 years, then patient donors with the diabetes, hypertension, malignancy, then the viral infections like hepatitis B, hepatitis C, HIV infections, then some infections like tropical infections and tuberculosis, which are specially important for our Indian scenario. Then surgically complex issues like the horseshoe kidney, cyst, renal stones, and each statement links with the clinical feasibility and risk mitigation and ethical responsibility. Coming to the donors with the AKI, AKI is very common, especially in the donor branded donors due to hemodynamic instability they have. Procurement biopsy is recommended for KDIGO stage 2-3. If less than 10% cortical necrosis was there, then there is a evidence that there is a comparable graft survival to the standard donors. There is one Maryland aggregate pathology index which predict the post-transplant outcome. This index involves the glomerulosclerosis, arterial hylinosis, as well as the interstitial interstitial and tubular atrophy as one of the criteria. If this index is less than 7, then we can definitely use the organs, and say 8 to 11 it may be a marginal organ, and more than 12 we have to discard the organs. Then so by using this, unnecessary discard rate is low. AKI grafts we have seen many times they performed well and have good long-term outcome. Coming to the extremes of donor age, elderly donors like more than 70 years, many times we have seen the living donation as well in the extremes of age. Even the donors like 77, 80 years has been reported and doing very well. So in deceased donor situation, the elderly donors were feasible for kidney and liver with proper evaluation. Pediatric donors like donors with less than 10 years of less than 10 kg of weight, where we can consider them for en-bloc kidneys are preferred, which have shown the better 10-year survival. So the key barrier is the in especially the children is the delayed brain death declaration, and with all this we can say that age alone should not preclude the organ harvesting if functionally sound. Another gray area is the malignancy and donor safety. Whenever there is a donor with cancers, there is a still dilemma to accept the that organs, and the time is very short, so we should stratify these malignancies with the minimal risk, especially in the for the cancers like skin cancer, thyroid cancers, and the bladder cancers, which are localized and non-aggressive tumors. There are some intermediate cancer like low-grade CNS tumors or renal tumors, and the low-grade CNS tumors. Then high risk are the active malignancies or the metastatic diseases in which the organ transplantation is contraindicated. So, but each and every case we have to informed consent has to be taken, and we should be transparent in our communication. Coming to the donors with the diabetes and hypertension, diabetic and hypertensive donors should not be automatically excluded. We have to assess for the nephropathy, retinopathy, and the cardiac diseases while evaluating the donor. Early diabetic changes has shown regression in the post-transplant period with a good control of disease, and the graft survival is also comparable when the disease is well controlled. Coming to the hepatitis B positive donors, anti-HBC positive donors are very safe for the hepatitis HBV negative or positive recipients with the prophylaxis. Earlier, hepatitis HBsAg positive donors were contraindicated for and reserved for only hepatitis B recipients. But nowadays we are using hepatitis B donors also with the prophylaxis and immunoglobulin, and lifelong prophylaxis with the lamivudine or entecavir. But strict monitoring for seroconversion and viral load has been recommended. Coming to the hepatitis C positive organs can safely be used in hepatitis C negative recipients with the directly active antiviral. We have good antivirals nowadays, and the transmission risk, though it depends on NAT positivity, but it achieves almost like 100% viral clearance and the excellent graft outcome in the post-transplant period. The major impact in terms of it reduces the waiting time, and it expands the donor pool. Coming to the HIV positive donor, this is also a crucial point where in 2013 US has made one law, that is HOPE Act, that is the HIV Organ Policy Equity Act, in which HIV donor and recipients transplantation is feasible. And after this law, there is a global ethics discussions all over the world about this utilization of the HIV positive donors and the feasibility of transplant. Even in India, we have seen the HIV positive transplants, and the inclusion criteria is like no active opportunistic infection, CD4 count more than 200 for kidney transplant, more than 100 for liver transplant, and it has shown comparable graft and patient survival outcomes. Our HOTA Act is not recommended for this is HIV positive donors is not recommended for the HIV negative recipients. Coming to other bacterial infections like MDR gram negative bacilli, MRSA, and the VRE infections. If there is a bacteremia, we should not go ahead for the organ transplantation. But donors with the pneumonia, we can use the other organs with the antibiotic prophylaxis, in which case we have to rigorously monitor the patient post transplant, and we have to use the antibiotic prophylaxis. Coming to the tropical infections, we know that India is endemic for the dengue, malaria, and lepto. In such situations, if the dengue is like post dengue donor is more than 30 days and the malaria lepto more than 3 months, then we can go ahead. And active infections, we should not go ahead in these infections. Coming to the tuberculosis, for active cases in disseminated TB or CNS TB, we should not go ahead, but post complete treatment with the AKT with smear negative, we can go with acceptable risk, and we should be transparent in communication with the recipient. Latent infection, where we can use the prophylactic anti-tubercular treatment, and we have to monitor the recipients with the microbiological and radiological screening in the post-transplant period. Coming to the surgical issues, especially the stones and the cyst, smaller stones like less than 4 millimeter, we can go ahead and we can just monitor in the post-operative period, but larger stones can be removed on the Bain surgery or Bain surgery. And then some cyst, if they are smaller, we can go ahead. Functional outcomes remains excellent with the appropriate evaluation. Our surgeon has recently presented one series of 9 cases where in cadaver transplant they have done the transplant in a PUJ obstruction. So surprisingly, it has not been properly evaluated during the evaluation, and when the graft has been taken for the surgery, that time the PUJ has been noticed, and still we have done the transplant and good outcome. Coming to the horseshoe kidneys, anatomically it is a challenging but still feasible. The options are either en bloc or divided transplantation with pre-surgical imaging to map the vasculature and the drainage pattern. We have to rule out the infection, obstruction, and the calculi before retrieval. So for this, we have ethical and regulatory oversight should be there from the recipient is essential, because there are the risk involved in doing this transplantation. So emphasis is on the post-transplant infection surveillance and documentation. So this consensus has documented various algorithms for the AKI evaluation, tuberculosis algorithm, especially the chemoprophylaxis and the recipient monitoring. It has structured the risk-benefit decision tree for the marginal donors. The impact is in terms of it reduces the avoidable organ discards, expands the donor pool without compromising the recipient safety, and promotes national self-sufficiency and regional equity. The strength of this consensus is that this is the first structured consensus on the deceased donors in Asia. It has involved multi-speciality, multi-regional expert representation is there, and it is especially for the Indian epidemiology and infrastructure. Limitation is that it is predominantly expert opinion based, as these are the areas where we cannot do the RCTs, but we have to see the retrospective analysis and the registry data. Further prospective validation in the Indian cohorts is needed. So implementation is like institutional adoption of the consensus framework, integration into the national transplant registries, regular audits and feedback loops, and the public and ICU level awareness to enhance the donor expansion. Then the key takeaways are the ethically expands the donor pool. We have to utilize the biopsy and algorithmic evaluation for decision making. It strengthens the screening for infections and malignancy, and promotes the more organ transplantation. So to conclude that, it offers a pragmatic evidence-informed framework for assessing marginal donors. It encourages the judicious utilization of the deceased brain-dead organs, aligning the medical feasibility with ethical integrity. So it is a step towards the equitable, self-sufficient and transparent transplantation in India, and this has been published in the regional Lancet Regional Health in the couple of months ago. And this position statement, as I just presented, it involves all the experts panel across the India. There are 19 statements were finalized, and if we see the consensus summary, almost more than 70% agreement is there. 11 statements had more than 80% agreement, and recommendation is that we have to be case by case donor selection, biopsy for the AKI. We have to evaluate for tuberculosis and assess the infection risk. We have to use prophylaxis for the viral infections, and this supports the inclusion of non-traditional donors using biopsy, infection control and case-based evaluation to expand the donor pool. Thank you.